Heart failure is a clinical syndrome in which an abnormality of cardiac structure or function is responsible for the inability of the heart to eject or fill with blood at a rate commensurate with the requirements of the metabolizing tissues. For a substantial proportion of patients, the most common causes of heart failure include hypertension. Hypertension increases heart's workload, and over time it leads to left ventricular hypertrophy. Valvular heart disease is another common cause of heart failure. Malfunctioning heart valves cause strain on the heart. As a result, the heart can't pump enough oxygen-rich blood around the body. Dilated cardiomyopathy causes the heart's chambers to enlarge. This makes the heart muscle thinner and weaker and lose their ability to contract and pump blood to the rest of the body. And coronary artery disease. Coronary artery disease is when your heart's blood supply is blocked or interrupted by a buildup of fatty substances in the coronary arteries. This reduced blood flow to the heart can lead to heart attack. Other causes of heart failure include diabetes, obesity, congenital heart disease, arrhythmias, infections in conditions like myocarditis, smoking, excessive alcohol intake, and pulmonary embolism. The typical symptoms of heart failure include breathlessness, fatigue, tiredness, and increased time to recover after exercise. Orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, and leg swelling. Less typical symptoms of heart failure include nocturnal cough, wheezing, bloated feeling, loss of appetite, confusion especially in the elderly, depression, palpitations, dizziness, and syncope. More specific signs of heart failure include elevated jugular venous pressure, hepatojugular reflux, third heart sound or gallop rhythm, and lateral displaced apical impulse. Less specific signs of heart failure include weight gain, cardiac murmur, peripheral edema such as ankle, sacral and scrotal edema, pulmonary crackles, dullness on percussion at the lung bases indicating pleural effusion, tachycardia, irregular pulse, tachypnea, Cheney-Stokes respiration, hepatomegaly, cold extremities, oliguria, and narrow pulse pressure. The New York Heart Association Functional Classification is a system used to assess the severity of symptoms in patients with heart failure. The classification ranges from Class 1 to Class 4 as follows. Class 1. There are no symptoms and no limitation in ordinary physical activity. Class 2. There are mild symptoms and slight limitation during ordinary activity. Class 3. There is marked limitation of physical activity. Class 4. There are severe symptoms at rest and inability to carry out physical activity. The American Heart Association classifies heart failure into 4 stages. Stage A. The patient is at a high risk, but no structural heart disease or symptoms. Stage B. There is a structural heart disease present, but no symptoms. Stage C. There is a structural heart disease with current or prior symptoms. Stage D. There is an advanced heart failure with symptoms at rest, requiring specialized interventions. Classification of heart failure based on ejection fraction is determined using echocardiography or other imaging techniques to measure the percentage of blood the left ventricle pumps out with each contraction. Heart failure with reduced ejection fraction is when the ejection fraction is less than or equal to 40%. It is caused by conditions that weaken the heart muscle, such as ischemic heart disease and cardiomyopathies. Heart failure with mid-range ejection fraction falls between 41 to 49%. It shares characteristics of both reduced ejection fraction and preserved ejection fraction. Heart failure with preserved ejection fraction is when the ejection fraction is greater than or equal to 50%. It is often associated with diastolic dysfunction due to conditions like hypertension or aging. Heart failure with improved ejection fraction is when an ejection fraction that was previously reduced to less than 40%, but has now improved to more than 40% with treatment. The precipitants of acute decompensated heart failure include non-adherence to heart failure medications, infection like pneumonia and sepsis, arrhythmias, volume overload caused by excessive fluid intake and renal failure leading to fluid retention, myocardial infarction, pulmonary embolism, anemia, thyrotoxicosis and pregnancy, aggravation of hypertension, infective endocarditis, rheumatic heart disease, viral and other forms of cardiomyopathies. The diagnosis of heart failure involves an ECG. A normal ECG makes the diagnosis of heart failure highly unlikely. Major features on the ECG seen in patients with heart failure include poor R-wave progression, axis deviation, atrial fibrillation, and bundle branch blocks, left or right ventricular hypertrophy, and pathological Q waves. Echocardiography is the gold standard test for characterizing cardiac dysfunction in heart failure, as it determines systolic left ventricular performance using left ventricular ejection fraction. Cardiac output, chamber sizes, regional wall motion abnormalities, identify valvular and pericardial disease. Determines end-diastolic left ventricular filling pressures for assessment of diastolic dysfunction and pulmonary artery pressure to diagnose pulmonary hypertension. Other laboratory investigations are required both to assist in the diagnosis of heart failure, evaluate for underlying etiologies, and to monitor patients. UEC to assess for renal dysfunction, a major determinant of disease progression. Full blood count to investigate heart failure, aggravated by anemia or infections. Heart failure associated with anemia is associated with poorer prognosis. Thyroid function tests reveal potential cardiovascular or thyroid disease as a cause of heart failure. Natriuretic peptides like BNP are useful in both diagnosis with very high sensitivity for ruling out heart failure at the lowest cut point. Troponin, T or I. Out of proportion levels may help guide the whether to do further investigations for ischemic etiology. Urinalysis, to investigate proteinuria due to nephropathy or nephritic syndrome, or red blood cells or casts due to glomerulonephritis. Lipid profile. Liver function tests may indicate liver dysfunction in liver failure or disease progression in liver congestion. Fasting blood sugar or HbA1c. Type 2 diabetes mellitus is more common in heart failure, serum magnesium and calcium. Low levels may precipitate reversible conditions like malignant arrhythmias, like torsade de pointes, or poor contractility respectively. Coronary angiography, to assess coronary artery blockages. Chest radiograph findings include pulmonary vascular redistribution, cardiomegaly, pleural effusions, interstitial edema, and curly B lines. However, in clinical practice, the chest X-ray will more often be used to rule out differential diagnoses like pneumonia, COPD, or PTB. The Framingham heart failure diagnostic criteria is a widely used clinical tool to diagnose heart failure. It divides diagnostic findings into major and minor criteria. Major criteria include paroxysmal nocturnal dyspnea, orthopnea, elevated jugular venous pressure, pulmonary rales, radiographic evidence of pulmonary edema, S3 gallop or third heart sound, cardiomegaly on chest X-ray, and acute weight loss of more than or equal to 4.5 kilograms in 5 days due to treatment. Minor criteria include bilateral ankle edema, nocturnal cough, dyspnea on exertion, hepatomegaly, pleural effusion, decrease in vital capacity by 1/3 from maximum recorded, and tachycardia of a heart rate more than 120 beats. Heart failure diagnosis requires at least 2 major criteria, or 1 major criterion and 2 minor criteria to be present simultaneously. The supportive management of heart failure include propping up the patient, giving oxygen when SpO2 is less than 90%, salt restriction, fluid restriction, manage exacerbating factors and correct reversible causes like anemia, infection, or thyroid disorders, smoking cessation and alcohol moderation, and weight management. The Fantastic 4 heart failure medications are the cornerstone therapies for heart failure with reduced ejection fraction, targeting neurohormonal pathways and improving survival. Angiotensin receptor neprilysin inhibitors like sacubitril valsartan. It is preferred over angiotensin-converting enzyme inhibitors, or ARBs, in heart failure with reduced ejection fraction. Reduces mortality and hospitalization by inhibiting the renin-angiotensin system and enhancing natriuretic peptides. Beta blockers such as bisoprolol, carvedilol, and metoprolol succinate. It reduces heart rate, improves cardiac output, and prevent ventricular remodeling. Mineralocorticoid receptor antagonists such as spironolactone and eplerenone. It reduces mortality, hospitalizations, and fibrosis. Monitor for hyperkalemia and renal function. Sodium glucose cotransporter 2 inhibitors like dapagliflozin and empagliflozin. Initially developed for diabetes, but now a key therapy in heart failure for reducing hospitalizations and mortality, even in non-diabetics. Other medications include ivabradine used for patients with elevated heart rates despite beta-blocker therapy. Hydralazine and isosorbide dinitrate for patients unable to tolerate ACE inhibitors or ARBs, especially in African American populations. Digoxin may be considered for symptom relief in refractory cases, but does not improve survival. Device therapy include implantable cardioverter defibrillators. It prevents sudden cardiac death in eligible patients with reduced ejection fraction of 35%. Cardiac resynchronization therapy for patients with desynchrony, like in left bundle branch block and symptomatic heart failure. Advanced therapies include mechanical circulatory support, like ventricular assist devices in advanced heart failure, and heart transplantation in refractory cases. Patients can be educated to emphasize on adherence to medications and lifestyle changes, and recognize signs of decompensation, such as sudden weight gain and dyspnea. And that's all for this video. If you find this video helpful, don't forget to like, share, and subscribe for more informative content. Stay tuned for our next video.